Assalamu alaikum. Good morning. Honorable Vice Principal Sir, my respected teachers, my beloved colleagues. I am Dr. Anita Fahmi Prapti, Intern Doctor, CBMCB. Welcome you all to today's clinical meeting on hair fall, reasons and solutions. Today's clinical session will be chaired by Dr. Sadequel Islam Ma'am, Associate Professor and Head, Department of Dermatology and Venereal, CBMCB. Co-chairperson, Dr. Shahidul Islam Sir, Associate Professor, Department of Dermatology and Venereal, CBMCB. Our today's speaker is Dr. Sadequel Islam Ma'am, Registrar, Department of Dermatology and Venereal, CBMCB. Now I am requesting today's chairperson Ma'am come to the dais with co-chairperson Sir and conduct rest of the session. Thank you all.
Assalamu alaikum. It is a great pleasure to welcome to you all today's clinical meeting hair fall, reason and solution. It is the most common complaint we eventually in clinical practice. Hair loss due to hormonal imbalance, stress, systemic disease. Hair is a vital organ, not our appearance, but also our confidence and self-image. When hair loss occurs, it impacts psychological, physical, and social impact. So now I request our today's speaker, Dr. Sadequel Islam Registrar, CBMCB, Dermatology and Venereal Department, to present her today's topics. Thank you.
Honorable Chairperson, Co-Chairperson, respected teachers, my senior and junior colleagues, and beloved intern doctors, Assalamu alaikum. I am Dr. Sadequel Islam. With kind permission of Chairperson, would like to present my topic. Thank you, Madam. Today my topic is hair fall, reason and solution. Hair loss, also known as alopecia or baldness. Alopecia is the general medical term for hair loss. There are many types of hair loss with different symptoms and causes. This is the basic structure of a hair. The picture is showing two parts of the hair follicle and hair shaft. Hair follicle is situated in the dermis of the skull and the expanded lower end of the hair follicle is called bulb of the hair. Hair bulb encloses a richly vascular connective tissue mass which is called papilla, which induces and maintains the growth of hair. When the hair emerges through the follicular ostia, it is called hair shaft. Hair growth is cyclic and it maintains phases, anagen, catagen and telogen phases. Anagen is the active hair growth stage that lasts between 2 to 6 years. Catagen is the transitional hair growth that lasts 2 to 3 weeks. Resting phase is telogen that lasts about 2 to 3 months. At the end of the resting phase, the hair is shed and the new hair replaces it. What causes hair loss? There are many causes. There are hormones, genes, drugs, autoimmune disease, stress, illness and childbirth, burns, injuries and x-rays and cosmetics procedures. Hair loss categorization. We broadly categorize hair loss into non-scarring and scarring alopecia. Non-scarring alopecias are alopecia areata, androgenetic alopecia, telogen efflavium, anagen efflavium, trichotillomania, tinea capitis, traction alopecia, and syphilitic alopecia. Starring alopecias are lupus erythematosus, lichen planopilaris, lichen sclerosus, and morphea. How we assess a patient when come with complaint of alopecia? At first, we take history from the patient. We take history about onset and duration of the hair fall, pattern, scarring, shedding or breaking or thinning, medical history, drug history, family history, about hair care and diet. We do examination, we do inspection and pull test. In inspection, we see on the scalp if there is any scarring, scale or erythema, pattern is diffuse or patchy, and density of the hair and hair quality. Investigations. Investigations done are ferritin, hormones such as thyroid hormones, sex hormones, anti-nuclear antibody, VDRL, TPHA, scalp scraping for fungus. Now, I am going to briefly discuss about alopecia with presenting some of our cases. Arabi, a 5 years old boy, 2 months history of hair loss, nail pitting present, no eating, no history of trauma, no other medical condition. Our diagnosis is alopecia areata. Now, what is alopecia areata? It is a chronic inflammatory disorder. Etiology is unknown, but there are some factors: autoimmune, environmental, and genetic. The lesion is non-scarring, patchy, or complete. May be associated with atopic dermatitis, Down syndrome, SLE, diabetes, thyroiditis, and vitiligo. Diagnosis by medical history and physical examination, that is periodic regrowth, nail pitting, examination of scalp, there is presence of exclamation point hair or not, scalp biopsy to examine hair follicle, and blood test to rule out other disorder. Treatment by options are oral and topical corticosteroids, intralesional injection of corticosteroid, topical minoxidil, oral genus kinase inhibitor, tofacitinib, and UVA. Prognosis: 80% regrowth in mild alopecia, 34 to 40% recover in 1 year, and progressive in 14 to 25%. Our next case is Muntahina, 8 years old girl, hair loss in a specific area for last 6 months. Broken hairs are observed, and our diagnosis is trichotillomania. Trichotillomania is a compulsive hair pulling. Onset in childhood or adolescence, mostly in girls younger than 10 years. Classic presentation is the Friar-Tuck form of crown alopecia, cause obsessive compulsive disorder, also associated with depression or anxiety. Treatment by habit reversal training and some medications, olanzapine, clomifene. Mr. Yusuf Ali, 32 years old male, gradual loss of hair started from vertex for 5 years. Our diagnosis is androgenetic alopecia. Androgenetic alopecia is a common form of progressive hair thinning, typically affecting the crown and anterior hairline in men and the parting in women. Cause: genetic sensitivity to dihydrotestosterone, which shortens the growth phase, that is the anagen phase of hair. Pattern: men experiencing receding anterior hairline and vertex bulging, while women see diffuse thinning over the crown, sparring frontal hairline. Progression by gradual miniaturization of hair follicle leads to finer, shorter hairs. Triggers: there are some triggering factors. They are genetic, hormonal imbalances, polycystic ovary syndrome, menopause or elevated dihydrotestosterone level. Treatment. Conventional medications are 5-alpha reductase inhibitors, topical minoxidil and anti-androgens. And here we do hair transplantation. Mrs. Lutfun Nahar, 20 years old female, localized discoid loss of hair with mother rash and photosensitivity. Our diagnosis was systemic lupus erythematosus. In scarring type of alopecia in lupus erythematosus, erythema, atrophy, follicular plugging, motile hyper and hypopigmentation are present. In active disease, anagen hair may be easily extracted from the involved area. Treatment: intralesional or potent topical corticosteroid, antimalarials, retinoids, Dapsone and sulfasalazine are systemic options. Nishat Tasnim, a 24 years old lady, losing handful of hair, sudden onset, history of delivery 5 months back. Our diagnosis is telogen effluvium. Telogen effluvium is excessive shedding of normal hair. Premature conversion of many anagen hairs to telogen hairs. Triggers are acute triggers. They are physical stress, surgery, high fever, severe illness or childbirth. Emotional stress, some medications. There are many medications, but these are commonly used medications in our daily practice. That is captopril, danazol, levodopa, propanolol. Chronic triggers, hormonal changes, that is thyroid issues, nutritional deficiencies and chronic illness. Diagnosis by history and physical examination, pull test and hip test. Treatment, no specific therapy is required. Drug-induced cases respond to discontinuation of the offending agent. Oral supplementation and balanced diet. Now, prevention of alopecia. Balanced diet, avoid tight hairstyles such as braids, buns or ponytails. Treat your hair gently when washing and brushing. A wide-toothed comb may help prevent pulling out hair. Avoid combing in wet condition. Avoid harsh treatment such as hot rollers, curling irons, hot oil treatments. Thank you.